Yes, I understand that every life must end. As we sit alone, I know someday we must go on. Oh, I'm a lucky man to count on both hands the ones I love. Some folks just have one, yeah, others they got none. Stay with me, yeah, let's just breathe. Practice all my sins, never gonna let me win.
Well, good Monday morning, everyone. Hopefully that was soothing enough of some music that it allows you to jump into your Monday maybe a little bit easier, not intended to be depressing by any means. But certainly, obviously, the video depicts individuals who have a directional preference, obviously, into flexion. And this is what we talked about this week. Actually, we talked about directional preference specific exercise, so also direction into extension as well as lateral shifting and such. So as we see in this flow chart, essentially, the treatment-based classification of specific exercise, it's really the first classification and the first level of classification that we go through when we're using this model. So I think a lot of our residents were a little bit surprised to see that in a sense, but it's really the area that we advise that you clear that out first and then you move on from there. And so we talked on the discussion boards a lot about obviously determining a direction, and in doing so, needing a good solid history from the patient and not just a very quick generic history. And then we also talked about what tissues may be facilitating that limitation, including things like the anterior hip structures in terms of tightness, and as well as the posterior structures limited in weakness. And so when we think about our treatment interventions, how do we manage that beyond even just its manual therapy approach? But speaking of manual therapy, we also discussed in a few of the studies, a few of the pragmatic trials, how influential the actual manipulation was on outcomes. And so in these trials, they were pragmatic in nature, and when we look back retrospectively, you see a lot of thrust manipulation performed at the spine as well as at the hip. And so I think a lot of the residents appreciated that, but they were a little bit surprised, I suppose, to see performance of manipulation on patients who have histories of stenosis and such. Obviously, ruling out any contraindications for manipulations is a primary must. We did also see this week, very well timed, a huge paper. If you haven't had a chance to see this and you want a copy of it, just let me know and I'll shoot it your way. But it was a paper by Delito et al. Who looked at surgery versus physical therapy. And actually they determined that the surgical outcomes and physical therapy outcomes were equally. There was no significant difference between the two, but there was significant improvements in both of them. So obviously PTs need to be seen as the solution, especially for this type of low back pain. And obviously we carry a lot less risk than does surgery. A couple housekeeping things. They have turned in their group projects. I think they're going to be doing some cool stuff. So again, if you get a chance and you have some residents in your region, ask them what they're doing, facilitate that, because I think that really helped out a lot last go around. And then this week, we're jumping into the psychosocial component of managing low back pain. That is all that I have right now. Thank you guys again for all your support for the residency program. I hope you guys have all a great week. I will see you guys later. Bye.
Meet you on the other side.